In my subspecialty, which is neuro-oncology, these cases, while not always emergent, have urgency to them, so we're able to proceed for the most part as we would have. For some of our cases, and particularly the skull-based procedures where we go through the nose, where there is the potential for a high viral load, we actually modified both the way we protect ourselves and the way we conduct the procedures. We were able to be innovative and in collaboration with colleagues at Mass Eye and Ear, create protective hoods around the patient through which we operate. And we also published a number of papers looking at the aerosolization of nasal particles that occurs during these skull-based procedures. Starting from some of the observations that occurred during the early COVID period, we will at least think very differently about risk to surgeons and everybody in the operating room during these procedures. And so therefore we'll have more thorough PPE, and we may even adapt some of the instrumentation to reduce aerosolization of particles. On another level, much of this surgery that we do is done through a microscope or sometimes using an endoscope. This may lead to a more rapid adaptation of what's called of exoscopic techniques, where the light source in a camera sits above the patient or the surgical field, rather than in between the surgeon and the field. And that will allow us to continue to wear very protective PPE during these skull-based cases.